So what we have is today a little different topic compared to the topics which you have been going through in the last week, and it's about coarctation of aorta. We will see today the basics about coarctation, the understanding embryology, the clinical manifestation, and a little about the diagnostics. And further, I think Dr. Nageshwar Rao will cover up the treatment part maybe 3 weeks down the line. So first of all, we will see coarctation is one of the diseases which is not that uncommon, and it constitutes 7% of the congenital heart diseases, and it's the 7th most common congenital heart disease. So it has the 7 number very closely associated. The incidence is around 3 cases per 10,000 live births, and males it's more common, but this is more in the neonatal age group. So when you find a coarctation in the neonatal age group, it's twice as common in males than in females. However, as you see older children, the older children, the females, it's more common, and especially the abdominal coarctation, it's more common in females. I think maybe somebody has not muted, so the sound is coming. The coarctation of aorta is one disease which has a very strong familial inheritance pattern, and the recurrence risk is relatively much higher compared to other diseases. Now, this is also true for all left-sided heart lesions, including hypoplastic left heart, aortic stenosis, etc. And the recurrence risk, in contrast to other diseases, is up to 10%. Now, normally the recurrence risk is in the range of 1 to 2%, and here it's in the range of 6 to 10%. So it's significantly on the higher side. And coarctation is one disease which is very heterogeneous in the sense that it could present in all the age groups with varying clinical symptoms, and it could either happen in isolation or it can happen in association with other defects. Now here this sex thing, I would like to just correct myself that it's more common in males than in females. However, in infants and in abdominal coarcts, we may not find a similar way of distribution in sex. Now, associated defects. So what associated defects are common with coarctation? One most important is the bicuspid aortic valve, and the second most important is the ventricular septal defect. And there are other few like PDA, transposition, AVSD, hypoplastic left heart, etc., where you have coarctation as an association. Now, very commonly, obstructive right heart lesion is rarely associated with coarctation. You will not find biventricular obstruction commonly, and very, very rarely you can have a tetralogy with a coarctation. So most commonly it's the left heart disease or any situation like a complex congenital heart disease like PGA, AVSD, where you can have a coarctation along with it. Like a classical tossing wing can have a coarctation, and the association of bicuspid aortic valve with coarctation is very high, and it's seen in up to 2/3 of the infants with bicuspid aortic valve to have coarctation, and 30% of children with coarctation can have bicuspid aortic valve. So this is a strong association with bicuspid aortic valve. So whenever you see a bicuspid aortic valve in a newborn, be very careful that the child does not have coarctation. The next association is seen with syndromes, and 5% of Turner syndrome will have coarctation. Also, there are other syndromes like neurofibromatosis, Williams disease, Sturge-Weber, which will have coarctation. Commonly, the last two, the Williams and the neurofibromatosis, can have abdominal coarcts also. And the last thing which coarctation is associated with is cerebral aneurysms, where they may get predisposed to cerebrovascular accidents, especially in older age groups when hypertension sets in. So what we saw so far is that coarctation is the 7th most common congenital heart disease, and it has more predominance in males. And also that the associated defects, the most common is ventricular septal defect in bicuspid aortic valve. Turner syndrome has a strong association. Now, what does coarctation mean? Coarctation means to contract. Actually, coarctate means contract. That means it's the narrowing. The congenital narrowing of the proximal thoracic aorta is defined as coarctation. What exactly happens histopathologically is there is a localized medial thickening with some infolding of the medial and superimposed neointimal tissue. So it's the media and the intima which gets affected, where there is some amount of thickening and infolding of that tissue. Now, by definition, it is localized and it is more in the proximal thoracic aorta. So the most commonest way of presentation is the discrete stenosis, which is close to the ductal area in the arch. However, it is not localized to only a localized stenosis and also only to the juxtaductal area. So it might be associated with a long segment narrowing. Sometimes there is hyperplasia of the associated transverse arch, and you can also have stenosis of the abdominal and aorta. So in terms of the degree of narrowing, it can vary from localized to long segment. It might be restricted only to juxtaductal area. However, it can also involve the abdominal aorta and the transverse arch. And hypoplastic transverse arch, there is a way to define it, and we will see in the next slide how do we define it. Now, along with this narrowing, you also have commonly dilatation of the descending aorta distal to the narrowing, and this term is called post-stenotic dilatation. And another common association is the presence of collateral vessels. Now, whenever we have obstruction in the arch, what happens is you have the vessels which pop off from the high pressure area. That means the segment proximal to the coa to the low pressure area. So from the upper part of the body to the lower part of the body below the level of coarctation. And how soon the collaterals can develop? Collaterals can develop as early as just few weeks of life. So now we will see how do we define a hypoplastic arch. So as we understand, this is the aortic valve. The ascending aorta is the segment from the aortic valve to the first arch vessel. From the first to the second is the proximal transverse arch. From the second to the third vessel is the distal transverse arch. The segment from the third arch vessel to the PDA is the isthmus. And after the PDA area, this is the descending aorta. So this is the juxtaductal area, and this is what is the isthmus. So commonly you have an isthmic narrowing or juxtaductal narrowing, but sometimes you might have this itself extending to a particular extent, or you can have involvement of the descending aorta, or you can have hyperplasia of the arch. Now exactly how many millimeters means it's hypoplastic is always confusion, because to define it as a hypoplastic arch, we need to follow these criteria. And for that, you'll have to measure the ascending aorta and then compare your respective segment with the ascending aorta. So if the proximal arch is less than 60% of the ascending aorta, or the distal transverse arch is less than 50%, or the isthmus is less than 40% of the ascending aorta, then it's defined as hypoplastic arch. So this is how we define hypoplastic arch. Now coming down to the embryology. So what exactly, which part of the pharyngeal vessel is affected? Now we can see here that we have 6 pharyngeal arteries, the first, second, third, fourth, fifth and the sixth. And as we understand, the first, second and the fifth usually disappear. And normally the arch is produced on the left side, uncommonly on the right. And on the left side, the fourth arch vessel contributes, and the sixth arch vessel contributes to the formation of the arch of aorta. So this is what is the left arch. The ductal tissue is produced from the distal part of the sixth pharyngeal vessel, and there are 2 theories why a coarctation develops. The first theory is called the ductus tissue theory, and the second is the hemodynamic theory. Now overall, the hemodynamic theory is much more acceptable. The ductus tissue theory says that the smooth muscle cell of the ductus migrates into the periductal aorta, that means the isthmic area, and produces narrowing. However, this does not explain a couple of presentations where you have the surrounding segment which is getting involved. You have a long segment coarctation, you have hyperplasia of the transverse arch, etc. And the second theory is the hemodynamic theory, which says that if there is any reduction of the blood across the left side of the heart, then it produces low flow, low volume of blood across the isthmus, and that itself can produce narrowing. Now, as we understand that the ductus carries a lot of amount of blood during fetal life and takes it and bypasses the upper part and takes the blood to the descending aorta. So the isthmic area otherwise has low flow. Now, if there is any additional reason why there is less flow, then it would result into narrowing of the isthmus. Now, this theory also has few limitations, and these two are only hypotheses to understand why coarctation develops. Now, this theory also helps us to understand why we do not have biventricular obstruction. So, if there is obstruction of the right heart, relatively the flow into the arch of aorta is going to be much better, and hence we do not have coarctation with etiology of Fetal. So, this theory supports that understanding, the second theory. Now, based on this understanding, we have two types of narrowing which can happen, the preductal and the postductal, and this type of classification is now I wouldn't say outdated, but it's not very well accepted. But initially, the traditional classification says that coarctation has two types. One is the preductal, where you have the narrowing before the ductus arteriosus, and the postductal, where you have the narrowing after the ductus arteriosus. Now, classically, the preductal form is considered the infantile form, and this constitutes significant number of coarctation cases, approximately 70%. The presentation of coarctation can happen, as we understand, across the ages, and one of the presentations is during the neonatal period. Now, during the neonatal period, classically it is preductal, where the ductus supplies blood to the descending aorta, and once the ductus closes, then it causes shock and hypoxia. Whereas the adult form, classically, usually does not have the ductus playing a role, and it's the narrowing in the postductal area. However, this is not exactly applicable to every single case. Now, what happens exactly when we have coarctation of aorta? So, we'll understand a little about pathophysiology. So, as we understand here, see, this is the ductal tissue, and here there is the coarctation segment. So, all the three vessels are coming proximal to it. But this is not how always coarctation is situated. You might have a coarc segment which involves the left subclavian. You might have a coarctation segment which is distal to the left subclavian. And you might have a coarctation where the subclavian is anomalously originating. So, you have a left arch with an anomalous right subclavian artery, in which case the right subclavian is also affected. Now, basically, we have this obstruction, because of which we have concerns with the proximal area in terms of load to the left ventricle. So, this can happen in isolated coarc when the PDA is open, or even after the PDA closes, you have an afterload created for the left ventricle. And because of which you can have various changes in the left ventricle in terms of left ventricular hypertrophy, and left ventricular hypertrophy will cause LA pressure rise, because of which you will have a foramen oval which is torrentially shunting left to right, causing again right heart dilatation. Now, this is one understanding where you have all the four chambers dilated, biventricular dilatation, you can have biventricular dysfunction, especially in a neonatal coarctation. Now, we need to also understand that in fetal life, the right heart is the one which shows signs for subtle coarctation in terms of dilatation. So, whenever we have right heart dilatation, you might have coarctation. However, the sensitivity and the specificity is 50-50%. That means that you might have coarctation and no right heart dilatation, and at the same time, you might have right heart dilatation but no coarctation at birth. Now, one of the theory to understand of fetal right heart dilatation or neonatal right heart involvement is this theory. And the second is, in fetal life, what happens is the isthmus does not carry much blood. So, if there is significant ischemic narrowing, a lot of flow goes up and comes back into the SVC as return from the upper part of the blood, upper part of the body into the SVC, into the right heart. So, the right heart is significantly dilated. So, one is the afterload increase for the left ventricle. And the second is, when you have significant narrowing, and if the PDA also closes, you have reduced systemic perfusion to the lower limb, including changes which can happen into the renal perfusion and the lower limb vessels, etc. So, once we understand this, there are two major things which happen with coarctation of aorta. One of which is collateral circulation, and second is systemic hypertension. Now, this is one of the papers you will be surprised to see as early as 1940s. This is one of the earlier papers and earlier studies on coarctation of aorta, which describes the disease as mechanical embarrassment. That means there is a mechanical problem to the circulation. And they had already found some 10 cases in 1940 of coarctation where there was collateral circulation, and this paper describes beautifully how collaterals develop in coarctation. So now there are a few interesting things to understand that primarily from the arch of aorta where the pressure is high, the vessels pop off and enter finally the descending thoracic aorta. Now one of the example is through the subclavian artery, and most of the collaterals develop through branches of the subclavian artery. And one of the artery which contributes significantly to collateral formation is the internal thoracic or the internal mammary artery, which is a branch of subclavian artery. And internal thoracic artery finally sends blood through the anterior intercostal to the posterior intercostal vessels, and then finally enters the descending thoracic aorta. This is actually what happens is there is a retrograde flow from the anterior to the posterior intercostal arteries. Now, as we understand, these intercostal arteries are situated in between the ribs, and they classically, we will see in the next picture how they classically are positioned in the intercostal space. Remember that whenever you have a chronic presence of coarctation, then collaterals commonly develop. As we understand that, if the coarctation is very severe, the baby is going to be picked up much early because of the degree of sickness. But if it's a little less severe coarct and it stays for a few weeks to years, then you will have collaterals developing. And interestingly, the first, second, 10th and 11th intercostal arteries do not participate in the collateral circulation. So they are primarily from the 3rd to the 9th intercostal vessels which get involved. And here we can see, this is the arch of aorta. This is the first vessel which then bifurcates. So this is the right subclavian and this is the left subclavian. And we can see here the internal thoracic artery is this one. So this is the internal mammary artery, which then gives rise to the inferior intercostal vessels, which then sends blood to the posterior intercostal vessels and then into the descending thoracic aorta. So this is one such cycle. Now you have this collateral developing at a couple of places. The second vessel where it develops commonly is the thyrocervical trunk. So this is one of the vessels of the subclavian artery. The thyrocervical trunk has a branch called descending scapular artery, and the descending scapular artery again sends blood to the intercostal vessels into the descending thoracic aorta. The second vessel is the thyrocervical trunk. The thoracoacromial vessel. The thoracoacromial vessel is not shown in this figure, but that is also one of the vessels from the subclavian artery, which supplies blood to the thyroid, and it gives rise to the transverse cervical. So this also gives rise to the scapular vessel, and then again it communicates with the descending thoracic aorta. And the last is the vertebral and the spinal arteries, which sends collaterals down to the descending thoracic aorta. Most of them anastomose with the intercostal vessels, but there are few which will also go to the epigastric vessels. Yeah. So now here we can see in this figure, this is the intercostal space. So this is the intercostal vessel which runs into the roof of that intercostal space. So what it does is the inferior surface of the particular rib is in contact with the vessel, which becomes then tortuous. And once it becomes tortuous, based on the degree of tortuosity, the indentation is produced. So this is how the indentation into the arteries is seen because of the collaterals, which develop and stay for a longer period of time and then become tortuous. So this is about the collateral development. The second thing which happens over time is the systemic hypertension. Now there are various theories about systemic hypertension, and probably it's the combination of a couple of things which causes systemic hypertension and described with coarctation. Now commonly you will see this in older children, and that's one way how older children are picked up to have coarctation. Now one of the theory which is explaining systemic hypertension is just the presence of mechanical obstruction. So you have obstruction to the flow of the blood, and because of which the pressure proximal to the obstruction increases. However, there are few things which this mechanical obstruction theory does not explain. Now, one of which is the degree of stenosis and the degree of hypertension. You can have a disproportionate hypertension for a child who has coarctation, not to that severity. The second thing is, in coarctation, distal to the obstruction, commonly you have your vascular resistance, which is high. This is peripheral vascular resistance. This is not pulmonary. So the peripheral vascular resistance distal to the obstruction increases, because of which your diastolic pressures are high and your pulse pressure is narrow distal to the obstruction. So this mechanical obstruction theory again cannot explain that component. And the last is, after treatment of coarctation, you still do not have blood pressures which normalizes immediately after the procedure. And there are times where it takes a couple of weeks or months, and in older children sometimes systemic hypertension can persist for years together. So this understanding is not being explained by the mechanical obstruction. And hence, the understanding that there are few other things like renin-angiotensin and the sympathetic nervous system also playing a role for systemic hypertension. Now, renin-angiotensin mechanism says that, the theory says that the renal blood flow, there is some amount of reduction because of proximal obstruction, which activates the renin-angiotensin system and then produces certain changes in the mediators in the body, which causes hypertension. And the last theory is doubtful, but they say that there is some role of the central sympathetic nervous system also. Now, this is about systemic hypertension. So the pathophysiology basically has an understanding that you have reduced flow to the distal area, you have proximal afterload and consequences on the cardiac chambers, you have collaterals, and then you have systemic hypertension. Now, clinical presentation. So there are ways how a coarctation can present, and as we understood initially, that it has a heterozygous presentation. It can present at different age groups and in different ways. Now, the presentation would also depend upon the associated lesion. However, here we are taking into consideration isolated coarctations. And remember that it's related to the severity of the lesion and not the site. Whether you have coarctation, which is present in the juxtaductal area, whether you have present in the transverse arch in terms of hyperplasia, or you have it present in the abdomen. The complaints are more related to the severity of the lesion. And the timing and the severity of presentation is based on three things. One is the extent of ductal patency, especially in newborns. The duct is patent, your presentation is going to be different. And if the duct is absent, it's going to be different. The rapidity of ductal closure, if the PDA closes slowly over time, then the presentation is going to be more insidious compared to rapid closure of PDA on day 2, and then it's going to be more dramatic. And the last is the fall in the pulmonary vascular resistance also. So there are few factors which decide the presentation. Also, we have to understand that in chronic situation, then you have collaterals which develop, which will also modify the presentation. And the last thing is your findings, which are also affected by the associated lesions like anomalous origin of the right subclavian artery, or the coarctation involving the left subclavian artery, or the presence of collaterals, etc. So now the presentation basically is divided into two ways, but every child does not follow exactly in these two patterns. You might have overlapping situations. So the first way of presentation is the critical coarctation, which happens in neonatal period. Now we remember that this is one of the disease which can go unnoticed at birth, and the baby could be discharged from with the mother after 48 hours in a very stable condition. So the child could look asymptomatic, and the child goes home, and after going home, in a couple of days, the child could come back in a very sick situation. And this happens because we understand coarctation is a ductal dependent situation. Now, can we prevent this? Maybe to some extent, yes. If we understand that the PDA was the structure which was keeping these children stable, then the saturations in the lower limb could have been borderline. So there is a role of prenatal diagnosis, one, or the role of pulse oximeter screening for picking up these babies. The role of prenatal diagnosis, as I told you, diagnosing coarctation in fetal life is difficult. To a significant extent, you can suspect it. Very few cases you can exactly be sure that it's going to be a severe coart. Now, whenever we are suspecting it, it's better to be taking precautions in delivering the child, understanding that there are chances that this may not turn out to be coart. So the counseling in antenatal period for coarctation is a little challenging and needs a lot of reassurance for the parents. It's a disease where you can neither provide complete guarantee and also not give them a very negative future. So the second way to understand is if you have chromosomal defects in the newborn or in fetal life, then you have to suspect coarctation in early life. Remember that only 5% of the turners are going to have coarctation. So whenever you have coarctation, the possibility of having turners is not that high. However, it's important to understand that in newborn period, you may not be able to pick up turners by phenotype very easily. So coming down to the presentation, what happens once the ductus closes? Again, remember, if the ductus closes acutely, then the child is going to be sick very soon. In terms of complaints of poor feeding, fast breathing, chest lethargy, and when the child presents to you, you could have cardiac failure, shock, and acidosis. The low limb pulses is a very common method of ruling out coarctation at birth. However, a routine habit should be there that whenever you see the baby in the first 1 month of life, keep checking the lower limb pulses because things could change after the PDA closes. And then if you have less severe coarc, then what happens? So if the PDA closes slowly over time and the coarctation segment is not that severe, then the coarctation could evolve over weeks or months. And in that situation, children can present just with a murmur, a systolic murmur, or with systemic hypertension. Sometimes older babies could present with complaints of frequent headache and claudication of the lower limb on exertion. So whenever a child presents in the later part of childhood or even adolescent age group with headaches or claudication, it's important to check the lower limb pulses. And also remember that only checking lower limb pulses may not be sufficient. Checking for radiofemoral delay is much more important because if you have collapses, your femorals could still be felt, but your radiofemoral delay could clinch the diagnosis clinically. So now what all can we see on examination? So this is one diagnosis. Coarctation is one diagnosis which can be picked up by pediatricians. Just on clinical examination, there are lots of congenital heart diseases where you can only suspect a congenital heart disease, but coarctation is something where you can clinch the diagnosis based on your examination findings. So as a routine, always have a habit, any child walking in your OPD, make sure that you check for lower limb pulses and in high risk situations, see for radiofemoral delay. Now exactly what happens? The upper limb pulses become bounding and the lower limb pulses have a slow rate of rise and a late peak. So you can understand that it's a slow rate of rise and a late peak with reduced amplitude. So there are three things which are different. The rate of rise is slow, the peak is later, and the amplitude is low. Now in addition to that, if you check your blood pressures, they will have low pulse pressure. So as we spoke in the previous slide, the lower limb, the peripheral vascular resistance is high, because of which the combination of the two, the low systolic amplitude and high diastolic pressures, makes your pulse pressure narrow. So the typical thing is that why is it that you have a late peak? And that's because the percussion wave for the femorals becomes very low. So what you're feeling is the tidal wave. Normally, your pulse wave will have a percussion wave and a tidal wave. So what you are actually feeling in the femorals is the tidal wave. And hence, you feel that there is a late peak. So this is about the pulses. And second thing is about the blood pressure. So as we understand, you have a systolic blood pressure gradient between the upper limb and the lower limb of 20 or more, then it clinches the diagnosis clinically. Normally, your lower limb pressure should be up to 20 more than the upper limb. So if it's equal also, then you know that it's not very close to normal. But if it becomes more, the upper limb becomes 20 millimeters more than the lower limb, then it says that this is clinical coarctation. And coarctation is one disease where your peripheral examination gives you a lot of information. However, your local cardiovascular examination also sometimes will give you a clue, and to my understanding, a biggest clue is ejection systolic click. So if you think that clinically you have an evidence of a bicuspid aortic valve, so bicuspid aortic valve will typically have an ejection systolic click, which is constant because it's on the systemic side. It does not change with respiration. You can hear at the left sternal border, second space, and also you can hear at the apex. If you have an ejection systolic click, as we understood, up to 2/3 of the children can have associated coarctation. And this is about the click. Now, along with that, you might have the thrill in the suprasternal notch or a short systolic murmur on the sternal border, both the sides or interscapular area. Now, these murmurs could be produced just because of the narrowed area, or you could hear it because of the collaterals. Now, you could also have a continuous murmur, not very commonly in the interscapular area or at the back, and which could be due to the coarcted segment or presence of collaterals. You might find the LV impulse, which is increased because of left ventricular hypertrophy or dilatation. So, and remember that coarctation, you can have LV dilatation, LV hypertrophy, RV dilatation, RV hypertrophy based on the age and the exact hemodynamic change which happens inside the heart. So now this is about the examination, and now we come down to the investigations. So as we can see here, in very younger age group, when the child presents in shock, then the X-ray could be not exactly specific to coarctation, but what you could see is some cardiomegaly and some amount of pulmovenous congestion, as we understood, because your LV end-diastolic pressures become more, which causes increase in the LA pressure and could cause pulmovenous congestion. The cardiomegaly could be a result of the PFO shunting significantly left to right and the RA and the RV dilated as in this picture, or you could have left heart dilatation. And later age group, the classical three sign which is described in practice, you sometimes only see it, and that's because of the coarctation where you had the post-stenotic and pre-stenotic dilatation of the aorta. So you can see here the classical three sign which you can see, the aorta and the narrow segment, but this is not that common. And in older age group, you could see what is described as the rib notching, as we understood in the collateral section some time ago. Remember that you will have changes from the 4th to the 8th rib classical, or 3rd to the 9th rib. Now, ECG is also not very specific to coarctation, and if it's an earlier age group, you could see the right ventricular hypertrophy, which is more than acceptable, and in the older age group, you have left heart dominance. So, LVH can be present in older age group due to pressure load. So, ECG is not something which is very specific, but sometimes it could give you a clue based on the axis of the heart. As you can see here, it's extreme right axis deviation with RVH for a newborn. And now coming to the echocardiogram. Now, echocardiography, there are a couple of things which we would like to see. Very important is the abdominal descending aortic tracing. So whenever you start an echo for a suspected coarctation, or I would say in general for any child, make sure that from subcostal you pick up the descending aorta and Doppler it. This is important because there are some coarcs, as we understood, which could be low into the abdomen or low thoracic area. And in that situation, you might not be able to profile it from suprasternals. And the descending aortic tracing, if it's meaned out, you know that there is a segment somewhere else, and you could use other modalities for investigating. So once you do that, if you have a pulsatile tracing in the descending aorta, it could rule out a severe coarctation. You can still have a milder form of coarctation, or sometimes coarct with significant collaterals where your descending aortic tracing is satisfactory. Now, as we can see here, you can have this left ventricular hypertrophy, which is there in this baby. And at younger age group, if you find an LV like this, then you pay attention to the aortic valve and the arch. As you can see in this figure, sometimes you might have LVH and a little LV dilatation, which you could see on the apical view. So pay attention to the aortic valve, and as you can see in this figure, the aortic valve is domain. A very subtle way to pick up an aortic valve which could be bicuspid in this view is this dilatation. So the ascending aorta will look a little bigger commonly with bicuspid aortic valve. And also remember that when you have this association with bicuspid aortic valve with coarctation, your counseling could be a little different because the chances of recoarctation are a little higher compared to isolated coarctation. So subtle signs like this, LV dilatation, LV hypertrophy, or bicuspid aortic valve could make you suspicious even before you put your color Doppler and even before you go into the further views. And as you can see here in this view, see the aortic valve and the ascending aorta, which is a little dilated. The left ventricular hypertrophy, so though even your function is normal, you still could be dealing with coarctation. And the classical bicuspid aortic valve, very important, always make sure you see your aortic valve morphology for any child. Now this particular thing I have kept because you can see here this descending aorta. So the descending aorta, you will see it from the subcostal, apical and parasternal views, and whenever you see this descending aorta, some amount of turbulent flow into the descending aorta here, you know that there is some coarctation, and this is another way to suspect it, even though your suprasternal does not show it. And then the aortic valve, if it's bicuspid, you have the gradient across the alveoli, and presence of aortic stenosis and coarctation together could sometimes underestimate each other. So remember, if you have severe aortic stenosis, your coarctation gradient could be underestimated. And the same way, if you have coarctation of aorta with significant gradient, your gradient across the aortic valve could be underestimated. And hence, your understanding of hemodynamics is important when you have combined lesion. Now, when you go to the suprasternals, and you can see here that your arch, so when the arch appears a little elongated, so remember, if any of the three segments is more than 5 millimeters in length, that still classifies itself as hypoplastic arch, and you need to be very careful with an arch like this. So this is the ascending aorta, this is the proximal transverse arch, this is the distal transverse arch, and this is the isthmus. The distal transverse arch is very commonly shortened in coarctation, and you have a length to the proximal transverse arch. And when you see a structure like this, then you know. But however, sometimes you have to focus on the anterior and the posterior shelf, especially in presence of the PDA. So you understand that this is the anterior shelf and this is the posterior shelf. Though our understanding is only on 2 dimensions in this view, when you have a PDA, you'll have to take an understanding whether would you think that this would turn out to be significant coarctation when the PDA closes. So make sure that you see your anterior and posterior segment and see whether this is present in all the cuts to understand whether it's completely concentric or not. Remember that coarctation can have an eccentric opening, can have a central opening, can have a shelf, can have a thick tissue there, etc. So it could be different varieties. And as you can see here, this is the left subclavian. So this is the left subclavian, and you have a narrowing just exactly here. So this is the juxtaductal narrowing, which is not involving the subclavian. Sometimes it could be involving the subclavian, and it's a discrete narrowing. Now, how do we know it's a discrete narrowing? The segment distal to the isthmus is important for us to open it up. And you here see that it balloons out. So the poststenotic dilatation starts immediately after the isthmic area. And the rest of the transverse arch looks okay. Now, all these have significant implication when we are deciding about the type of surgery, the extent of surgery, etc. And always remember that in coarctation, you figure out all the arch vessels. As we say that, it's important to make sure that the first vessel is bifurcating so that you rule out an aberrant right subclavian. Now, this is something you can do clinically also. So, whenever you palpate your pulses, it's important to palpate the right upper limb and the left upper limb separately and one of the lower limbs. That is sufficient. So, your right upper limb is felt well, your left upper limb is felt well, and the lower limb is not felt well, then you know that your narrowing is distal to the left subclavian. And if the left subclavian is not felt well, it's understood that your subclavian is involved into the coarc segment. So this is how you would do the clinical examination. Now sometimes you might have an arch like this. Now on 2D it looks like it's pretty normal, but your sense of suspicion is very, very important. If you have seen your LV which is not behaving normal, you have a bicuspid aortic valve, you have a mitral valve which does not look normal in terms of papillary muscle or a supramitral membrane, then you should put color, and this is very, very important. You can see here, grossly it looks like a normal arch, but you see that flow which is a trickle of flow actually present at that particular narrowed segment. And then you have a post-stenotic ballooned out segment. So this is severe coarctation in fact, and this is something which could have been picked up in descending aortic tracing, which would be leaned out. Now classically, if you Doppler the coarctation of aorta segment, you will get a tracing which is called a double envelope, and that's because you have a tracing of proximal segment and you have a tracing of the distal segment, and you have classical meaned out tracing because you have a diastolic spillage. I'm sorry, I wouldn't use the word meaned out, but it's a diastolic spillage. So this is how an envelope sign will come, and you have a diastolic spillage. Remember that your peak gradient is important, your mean gradient is important, but your diastolic flow is the most important. You might have a velocity up to 3 meters per second, 3.5, but if you have it only in systole, then you know that it's not a severe coarctation. So you will take into consideration your mean velocity and your diastolic flow more than your peak velocity to decide the severity of coarctation. So here you can see that the peak velocity is reaching 4.5 meters per second, and you have a mean gradient of more than 30. Overall, definitely classified as coart and definitely severe coarctation. So now this is the understanding on echo, and at the end of echo, just take home message is that you always have to check for your descending aorta diaphragm for Doppler tracing. Always put color also. Sometimes on color you will see that diastolic spillage which is happening. So the flow happens in systole and diastole both. That means that you have a significant proximal arch obstruction. Look for indirect signs like left ventricular hypertrophy, dysfunction, and right ventricular dilatation in a neonate. Now, if a PFO direction of shunting is also very important. For example, if your PFO is torrentially shunting left to right in the neonatal period, you know your LA pressures are very high. And also the direction of shunting could sometimes help you. Check for associations like bicuspid aortic valve, mitral valve disease, presence of PDA, etc. And when you have presence of PDA, understand that your coarctation assessment is a little more challenging. See the whole length of the arch and the descending aorta arch thresholds also, and then check for PA pressures for the whole understanding and deciding the further line of management. Now, there are few things with coarctation which can stay with the child forever in life, and hence remember that all babies with coarctation need lifelong follow-up for complications. Now, one most important is persistent hypertension. Younger age group, most of the time, hypertension resolves after surgery, very soon after surgery, and does not stay with the baby long term, but the older babies can have persistent hypertension and may need medications for a longer time. The chances of decoarctation can also happen with these babies, and the first 1 year of life the chances of decoarctation are high, and then the second peak comes during their pubertal spurt. However, you will follow them up closely in the first 1 year, and after that definitely yearly. And chances of aortic aneurysm also can be there, especially when you have associated bicuspid aortic valve. Also that later in life, if you have systemic hypertension which is persisting, you have risks of cerebrovascular accidents, especially if you have associated cerebral aneurysms. And hence these babies need long-term follow-up, not to forget about good oral hygiene, possibility of infective endocarditis later in life. Now, the take-home message for this class is that most of the babies with coarctations will appear well in the first 48 hours of life. So, remember that you need to see all your antenatal scans where anybody has suspected anything abnormal in terms of chromosomal abnormality or any suspicion about coarctation or left heart being small, right heart being bigger. And fetal right ventricle is the systemic ventricle, and hence the right ventricle handles more blood even in left ventricular obstruction. In the newborn period, check your upper limbs and the lower limbs in terms of pulses and saturations for every single baby, and also check both the upper limbs. In ECG of a newborn, if you have extreme right axis deviation or RBH, then you have to be more cautious. In older children, palpate your brachials and femorals simultaneously. So always check for a radiofemoral delay and not only presence of femorals. Blood pressures need to be recorded in both the upper limbs and one lower limb, and lifelong follow-up is a must for all our babies who get diagnosed with coarctation in neonatal life. We are done with our class today. Thank you so much for your patient listening. Any questions from anybody, please? Okay, so I have a question here. How is the severity of coarctation estimated in those with a large PDA? I agree with this situation, and I feel that this is a little challenging, and over years you develop your strategy. Now, if you understand that your clinical situation is that the baby is completely stable and your lower limb pulses are very well felt and there is absolutely no component of failure, then what you would do is on echo you will have to pay a lot of attention to how those shells are looking. Now, if your shells are looking as if you have an anterior and posterior shelf both, but it does not look very tight and your PDA is very large, then you will definitely have to follow up. Most of these babies do not turn out to have severe coarc, but you will have to monitor them on a regular basis, sort of in the ICU to monitor the lower limb pulses clinically, and daily echo to see when the PDA reduces in size simultaneously, how is that shelf appearing. On the other side, you might have a situation which looks like the narrowing is severe, and even if you have a large PDA, then it does not matter. Now, in that situation, you might consider just early surgery and not wait for PDA to close, keeping prostaglandins standby. Also, pay a lot of attention to your clinical scenario every day. Now, if you have a component of failure which is setting in slowly, then you pay a lot of attention to what is causing your failure in terms of how much your PFO is shunting, the gradient across the PFO, your right heart dilatation, your PA pressures. All these things might give you a clue that actually there is a coarc which is sitting in, which is severe in spite of you having a large PDA. So it's a combination of these two things which will help you to decide how severe is the coarctation. But I think it's a sense of judgment which you will get over years, which will tell you whether you want to monitor this child for the next 72 hours or you want to just plan for elective surgery. But it's a 2D understanding of the lesion along with the rest of the clinical findings in terms of failure and also echo findings in terms of pH, direction of PFO shunting, the way LV is, the way RV is.